Fabulous, thank you. Hello everybody and welcome to Dermoscopy for Absolute Beginners. I'm Chin Wybrew, I'm a GP in Cheltenham. Today, normally when we do this, we would normally have sponsors and we would normally have the reps talking to you over coffee and over lunch. These are all our sponsors. None of them are here today because we're all socially distancing and restricting the numbers to less than 30 in total. The aims of the session today. What we're going to try and do today is we're going to help you to understand what dermoscopy actually is and why it's so valuable in general practice. We're going to show you how to handle dermatoscopes and how to get the best use out of a dermatoscope as a GP, and learn the basics of interpreting what we're looking at and how to get into the habit of seeing things and building up your knowledge base. Now, why? Why do we bother with this? Well, partly to improve the recognition of skin lesions and their management, partly to improve referrals of lesions on a 2-week wait and the quality of lesions we're referring on a 2-week wait, partly to pick up melanomas earlier, but more in fact to avoid referring benign lesions. And that has a huge benefit to the patients. And one of the main benefits it has to the patients is if you say to someone, I'm worried about this skin lesion, and I'm going to refer you up to hospital because I think it might be a skin cancer, they then go home and they've got to wait 2 weeks in general, because that's how the 2-week wait works. So they wait the full 2 weeks. During that 2 weeks, they are writing their will. They are putting their finances in order. They're convinced they're going to die. They're sorting out everything, which might not be a bad thing anyway. And then they go to the 2-week wait clinic. Someone gets out a dermatoscope, has a quick look and says, nah, that's just a SEB-K, off you go. 2-second consultation. That emotional roller coaster is bad for people. It's also a benefit to us because actually doing a 2-week wait referral does take a little bit of time, and just being able to have a look and say, no, that's fine, off you go, will save us time in the consultations as well. But quite apart from anything else, actually, this is really quite inspiring stuff. It's very, very pretty dermoscopy. You look through the scope and it opens up a whole new world of beautiful things to look at. And that's the key thing that I want to get across to you here. This is fun. This is exciting. This is great. I love doing this. So the structure of the day today, we're going to have the why do we need dermoscopy, and I'll talk about that in a little bit more detail. We'll do some general useful information. Then we're going to talk through some common benign lesions, and we will cover all of the things in this list. Then we're going to do the common skin cancers, BCC, AK, Bowen's, a little bit on SCC, a little bit on melanoma. And then we're going to talk about other uses of dermoscopy in primary care, because it's not just skin lesions. It's so much fun for all sorts of other things and at home, but I'll show you that at the end. Now, there are different ways of learning. You can either learn by learning the features and the rules for various lesions, or you can learn just by looking at lots of pictures. And a lovely study that they did, I can't remember, it must have been, it was either Italy or Austria. They did a study with medical students, teaching them dermoscopy, broke them up into 2 groups. One group got taught the rules and pictures. The other group were just given pictures. So they would say, here's a picture. This is a melanoma. This is a SEB-K. This is a BCC. They all had the same length of time teaching. They then put them in a room and gave them all the same test. And both groups did equally well. So on average, people will learn perfectly well either way you do it. And so what we do is we do a mixture. And so we're going to use a combination of those techniques, and we're going to have lots of pictures. If you are a lots of picture person and you get really into dermoscopy, there is an app called Dermoscopy, and it is very, very addictive. Just be careful you don't open up this app for the first time at 10 o'clock in the evening, because you won't go to sleep that night because you'll be doing it all night. But it's really good fun. It's probably a little bit advanced if you've just done this bit, but for later on, it's really good fun. I recommend it. Now, the other thing that's really important for these sessions is interaction. And we have got these coloured cards, which should be about the only thing you have in front of you, apart from the piece of paper. You are going to need these. We're going to use these for our audience participation. Please feel free to ask questions. We may or may not answer them as we go along. Put your hands up, write down any questions that you have at the end. That's absolutely fine. If we're saying something and you've got completely lost, please do just make us pause and we will try and explain it at the time. And I'm going to start off with my getting to know you by the show of hands. So, how many people here, can you put your hands up if you are a nurse? Brilliant. Are you in primary care, secondary care? Primary care. Fabulous. Doctors? Okay. Are you... Right, hands up if you're a fully qualified GP. GP registrars? Hospital doctors? Medical students? Any other kind of doctor that I haven't thought of? Okay. Podiatrists? HCA? Paramedic? Anyone, anything else? Physician associate. That's what I haven't got on there. Thank you very much. I will add that to the slide. That's fantastic. I think you're you are the first physician associate we've had here. Welcome. Everybody is welcome. This is a nice cartoon. I have a suspicious looking mole on my shoulder. Right, why do we need dermoscopy? We've been diagnosing lesions on clinical grounds for years. So what is so good about dermoscopy? What difference does it really make? Well, we're going to start by thinking about melanomas. And with melanoma, there are some clinical algorithms that we will all have come across, of which the commonest one that people would use would be the ABCD rule, which I've added an E to on here. And there's an F and a G, but we'll come to that. So the ABCD rule is asymmetry, border irregularity, colour, meaning more than 2 colours, diameter, usually greater than 6 or 7 millimetres, and then you can add the E for evolving or erythema. And this has a few issues with it, because there are some benign moles which look irregular in shape, and so this looks like an asymmetrical shape, but actually if you put the dermatoscope on, you can see that the structures within it are symmetrical. Then you have the weighted 7-point checklist. And this one is the one that's on the 2-week wait referral forms. So this is your major features of change in size, irregular colour, irregular shape, and your minor features of diameter greater than 7 millimetres, inflammation, oozing, crusting or bleeding, and change in sensation. Well, let's just look particularly at oozing, crusting or bleeding. Oozing, crusting and bleeding are a really late sign of melanoma, and if we're waiting for it to get to that size, then that's a bad thing for us to be doing. We want to be picking them up before they get to be looking like this. So now we're going to have a little game. This is one of my favourites. Here we go. So in this game, what we are going to do is we're going to vote on which of these we think are melanomas. Now this is a simple show of hands. So if you think that the lesion is or could be or is likely to be a melanoma, put your hand up. So we'll start with lesion 1, this one here, top left. So hands up who thinks that might be a melanoma. So what do you think it is if it's not a melanoma then? A chalazion? Okay. Right, this one's a Spitz nevus. Has it come up? There we go. That one's a Spitz nevus. How about number 2, this one? Hands up, could be a melanoma? Yeah, that one's a blue nevus. Number 3, this is on a foot. Hands up for melanoma. Yeah, that one's just a bruise. This one here on a face, hands up for melanoma. Yeah, pigmented BCC. This one here, hands up for melanoma. No hands up at all. Yeah, that's a melanoma. This one here, hands up for, this is a game. Hands up for melanoma for this one. No, this one's a halo nevus. Hands up for melanoma for that one. Yeah, that's the easy melanoma. Hands up, melanoma for that one. Yeah, a few. That's a Seb-K. This one down here, melanoma for anyone? No. That one is a blue nevus. This one here, melanoma for anyone? No, that's a benign nevus. This one here, yeah, could be, it's a nevus. This one here, melanoma, it could be. It's not, it's a dermatofibroma. Bottom left, melanoma for anybody? No, it looks like a brain, doesn't it? It actually is a brain-shaped ZK. This one here, number 14, melanoma? Yeah, lovely, that's a dermatofibroma. Interestingly, we know that because we have the histology on it, because it looks really suspicious clinically. This one here, again on a foot, I think, might be palm, melanoma. Yeah, that's a melanoma. And then this one here, yeah, and that's actually a seborrheic keratosis that, again, we only know because we've got the histology. So we're not brilliant at picking them out clinically. So how about the ugly duckling rule? Now, this is what we actually do in practice. The ugly duckling rule for the patient is if a skin lesion catches your eye and makes you think, what's that? You need to come and ask us what it is. Okay, that's easy. And ugly ducklings can be any colour, shape or size. And this is what we actually do in practice ourselves. If we are listening to somebody's chest because they've come in with a chest infection, if we were, before March, listening to somebody's chest because they've come in with a chest infection, what we would do is you lift up the shirt, you have a look, and something catches your eye, and you think, oh, I'm just going to get out the dermatoscope and have a closer look at that one. So this is what we do in practice. The thing that catches our eye, we say, oh, what's that? So if something makes you think, what's that? Just have a look at it.